Hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. This episode is part of a series that I'm doing on high blood pressure, also known as hypertension. And in a recent episode, I covered what is normal blood pressure versus high blood pressure and how high is too high in older adults. So in this episode, I'm going to follow up on that, and I'm going to go into the treatment of high blood pressure and how we can otherwise help people lower their blood pressure. So if you haven't seen the previous video on high blood pressure, I hope you'll go watch it, because that's where I cover the basics about hypertension in older adults, including things like what is normal blood pressure versus high blood pressure in older adults, how we define hypertension, how we measure blood pressure accurately to make sure we can do a good diagnosis. I cover the causes of high blood pressure in depth, the signs and symptoms of high blood pressure, why it's bad for your health, how high is too high and when to treat. And I also cover the guidelines and goal blood pressures for treatment of high blood pressure in older adults. So that's what I covered in the first video. And now in this one, I'm going to do a little bit of reviewing of that, but I'm going to really focus more on our options for lowering blood pressure and treating blood pressure. So we're going to get started on that. But before I get into that, I have a very quick request, which is if you are here and you find this topic interesting, or you've been finding my video podcast interesting, if you haven't subscribed yet, could you please go ahead and subscribe to my YouTube channel? It would mean a lot to me. It does help me out a lot because it helps other people find the channel when you subscribe, and it does help support the work that I'm doing. So thank you so much. Now, moving on. In this particular episode, I am going to do a quick review of what is hypertension, the definition and causes, and how high is too high. And then I'm going to go into options for lowering blood pressure. And I'm going to talk about lifestyle options and then pharmacological options. So, drugs, medications, basically. And I'm going to tell you about which are the most important medications that are considered first-line therapy for the treatment of high blood pressure in older adults. After that, I'm going to talk a little bit more about some special considerations when it comes to treating high blood pressure in older adults, some of the things that we commonly see in geriatrics, especially when it gets to people who are age 80 and older. And then I'm going to just review what you can do if you're concerned. So, really quickly, what is normal blood pressure and what is high blood pressure? So as I explained in the previous video, normal, also known as optimal blood pressure, is a blood pressure less than 120 systolic. That's the pressure when your heart beats, the higher pressure, and 80 diastolic. That's the blood pressure when your heart relaxes. So that's basically the top number and the bottom number when we measure blood pressure, and it is measured by convention in millimeters of mercury. And that is considered normal, optimal blood pressure, no matter what your age, what your gender. We used to believe it was normal for older adults to have higher blood pressure. Well, it's common, but it's no longer considered normal. But high blood pressure is very common, and it becomes increasingly common as we get older. So even if you had normal blood pressure when you were in your 30s, 40s, 50s, you might end up with high blood pressure later in life. And I'll touch on the reasons for that in a moment. So the definition of hypertension in the United States right now, based on the latest guidelines, which were released in 2017, it's defined as a systolic blood pressure greater than 130 or a diastolic blood pressure greater than 80. However, in Europe, where they have experts that create guidelines too, and their guidelines were issued in 2023, they define hypertension as a blood pressure greater than 140 over 90. Either way, accurate measurement of blood pressure is essential. And you want to keep in mind that high blood pressure does not usually cause symptoms. So it is usually something we diagnose because it is noticed on a blood pressure check, and then we can confirm it through some careful follow-up checks of the blood pressure. So usually we don't see symptoms, although if the blood pressure is very, very high, such as over 180 over 120, people might experience symptoms, and I covered those symptoms in the previous video. So again, I covered this in depth in the previous video. These are the current definitions of hypertension based on the US guidelines from the American College of Cardiology and the American Heart Association. And again, it does presume accurate measurement technique, and it applies to all ages and genders. And then in Europe, their guidelines are a little bit different. They're still choosing to define hypertension as starting as 140 millimeters of mercury. Now, everyone agrees that what is optimal is less than 120, that everyone is in agreement on that. So what causes high blood pressure? Most high blood pressure is what we call primary hypertension. That means it's not due to an easily identifiable medical condition or medication. So the causes and risks of primary hypertension include advancing age. That's because getting older tends to make blood vessels stiffer, and that increases blood pressure. Obesity, genetics, family history, high sodium intake, high alcohol intake, physical inactivity, insufficient sleep, social stressors, and noise and air pollution are all factors that have been identified as risk factors for primary hypertension. And then some people do have what we call secondary hypertension, which means it's due to medications, drugs, or certain medical conditions. And I wanted to highlight this because, as you'll see, part of the treatment of high blood pressure is to check for these causes of secondary hypertension. So some of the causes can include medications, nonsteroidal anti-inflammatory drugs such as ibuprofen, especially if they're taken every day, can cause high blood pressure. Stimulants, steroids, many other medications can raise blood pressure. Drugs such as cocaine and amphetamines can raise blood pressure. Kidney disease, especially if it's quite severe, can raise blood pressure. Sleep apnea. And then there's also hormonal imbalances, which are sometimes caused by tumors, actually, that are secreting extra hormone. Why is hypertension bad? Again, really briefly, lots of research has shown that chronic hypertension, that increased pressure on your blood vessel walls, causes over time many serious health problems. So it damages the walls of the body's arteries over time. This can lead to problems such as stroke. And that high pressure, your blood vessels are going into every important organ of your body. That high pressure can eventually damage the heart, the kidneys, or the brain. So it's associated with cardiovascular events, heart attacks and strokes, and death. And then when it damages organs, it can cause problems such as heart failure or kidney disease or even vascular dementia. So what we know is the higher the blood pressure, the higher the risk of related problems. So treating hypertension and lowering blood pressure does reduce this risk. We know this from lots and lots of studies that when we bring blood pressure down, those problematic downstream effects also become much less likely. How high is too high? So generally, high blood pressure should be treated to get older adults to at least a systolic blood pressure of 150 or lower. So lots of research has shown that you get lots of benefits from getting people who have a blood pressure in the 170s, the 180s, down to the 140s. The actual goal blood pressure to target does depend on people's age, health status, and which guidelines. The American guidelines recommend that if we're treating high blood pressure, we try to get people below a systolic of 130 for all ages. They do have a little caveat that if people have limited life expectancy, is what they call it. It means that they're so ill, so frail, or so old that we don't expect they're going to live for more than, a year or two. Then they say you can reconsider that goal. European guidelines, on the other hand, which are more recent, allow higher goals for older adults. And so those guidelines say that if people are aged 18 to 64, we should target a blood pressure less than 130 over 80. If people are aged 65 to 79, it's recommended to target less than 140 over 80. And then if the person is tolerating that treatment, it means they've been successful getting there, their medications or whatever is the treatment plan isn't making them feel unwell, and they would like to go for lower, then you aim for lower. And then for ages 80 plus in Europe, they recommend a target blood pressure, basically a systolic in the 140s is what they say, 140 to 150 over 80. So it's important to keep the goals in mind when we're talking about treatment, because we do want to be thinking about, well, where are we trying to get to, right? So let's now get into how to lower blood pressure. So here are the key steps, and then I'm going to go into depth into many of them. So step one is you want to make sure that the blood pressure is measured accurately. And if you want to learn more about how to do that specifically, I recommend the other video. But ideally, you want people to sit quietly for at least 5 minutes, have their arm up at heart level when their blood pressure is being checked with a properly calibrated machine. And it's most accurate to take a few checks in a row with a rest period in between and average them. Next, once we're sure we have an accurate view on what the person's blood pressure seems to be, we want to check for causes of secondary hypertension. So we want to check for underlying causes and see if we can treat or remove any of those. Next, we want to decide on the goal blood pressure being targeted. We want to discuss and implement lifestyle changes that lower blood pressure. Then often we are going to need to start, or if the person has already been under treatment, we might need to adjust the treatment with blood pressure medication or possibly adjust other lifestyle changes. But what's most common is that we're there adjusting medications. And it's especially important to address this if the systolic blood pressure is over 150. Next step is to follow up to assess the effect and side effects of the blood pressure treatment. So that follow-up part is really important. Often it takes a little trial and error to figure out what are the right medications or the right combination of medications and lifestyle factors that will get somebody to goal. So we always want to have a plan for follow-up. We want to see how well our treatment plan is working in terms of the effect on blood pressure. We want to check and make sure the person isn't having side effects that indicate that maybe that kind of medication isn't a good fit for them or that are being really bothersome to them. And then we want to keep kind of adjusting that treatment until we reach goal blood pressure. And then optional would be to reassess the goal blood pressure once we reach it and decide whether we want to aim for even lower. So for instance, if we have been treating somebody who is over age 80 and we got them to 140, do we want to aim for lower and see if we can get them to 130 or a little lower, or possibly even lower than that if applicable? So let me now talk a little bit more about some of these particular steps. So again, checking for secondary hypertension. Often this starts off with checking for medications, and we do always want to be asking about over-the-counter medications as well. We want to be checking for drugs and medications that can raise blood pressure. And then we want to ask ourselves, could there be kidney disease that is contributing to this? Could there be sleep apnea? Are there signs of some kind of hormonal imbalance that often shows up actually with abnormal levels of electrolytes or sometimes of other hormones? So occasionally we do find a secondary cause of hypertension, or we would want to reduce or stop any medications that are aggravating high blood pressure unless they are absolutely necessary. And then this isn't always done in a busy primary care visit, but ideally we would talk about ways to lower blood pressure through lifestyle measures. And so what kinds of lifestyle measures lower blood pressure? So this here is a list that is modified on the one that I found in uptodate.com. This list summarizes many lifestyle changes that have been studied in randomized trials and shows you the average reduction in systolic blood pressure. Now, what's interesting about lifestyle changes is that many of them have a different effect or a more pronounced effect in people who have high blood pressure than in people who have normal blood pressure. So here I've listed the reported average reduction in systolic blood pressure in people who have hypertension. So one of the most effective interventions is something that is called the DASH diet. I'm going to talk a little bit more about that in a moment. Has reduced blood pressure by up to 10 to 11 points in people with high blood pressure. Reducing dietary sodium by about 1,000 milligrams a day. Generally, they're trying to get people down to a level less than 2,000 milligrams a day. So to 1,800 milligrams or maybe 1,500 milligrams. That can reduce blood pressure by 5 to 6 points. Aerobic exercise can reduce blood pressure, effect estimated at 5 to 8 points. Resistance exercise also can reduce blood pressure, maybe not quite as much as aerobic exercise, but still very good. Reducing alcohol intake, 4 points. Increasing dietary potassium up to 4 points. Weight loss, in some cases, maybe 1 point per kilogram loss. Now, a kilogram is 2.2 pounds. So if somebody loses, let's say, 5 pounds, that's about 2 kilograms, so maybe 2 points. And then I decided to add to the list quitting smoking. So it's interesting. Smoking is definitely not good for your health and not good for your cardiovascular health. It's unclear what the effect is on blood pressure. Very short term, smoking tends to increase blood pressure, especially in people who don't usually smoke. It's been debated in regular smokers how much it affects their blood pressure. But I put it there anyway, because if you're thinking about improving your lifestyle for your heart health, you should, if you are smoking, you should definitely consider quitting smoking. So let's now talk about a few of these lifestyle measures in a little bit more detail. How about the DASH diet to lower blood pressure? So DASH stands for Dietary Approach to Stopping Hypertension. And this is a diet that was studied back in the late 90s. The first major study report was published in 1997. And in this case, they actually fed people the diet. And the diet involved a high intake of vegetables, fruits, and low-fat dairy, and then a low intake of snacks, sweets, meat, saturated, and total fat. And the original study was done on about 450 people. They were actually not that old. The average age was, I think, 45. So I think most of them were in kind of like their 40s and 50s. But it did work to lower blood pressure. They found that blood pressure fell by 11 points in people who were hypertensive versus only 3 points in people who had normal blood pressure. So subsequent to this, a number of DASH-related trials have been done over the years. And in general, what they find is that when you change people's diet, you see an effect on blood pressure within about 2 weeks. So if it's going to work, you should see it by then. And then they've tried variations of it. And so they have also tried a low sodium DASH diet. The original DASH diet was not low sodium. And they have found that that tends to reduce blood pressure even more. So let me now talk for a moment about reducing dietary sodium. Now, you may have heard that a low-salt diet is good for your heart or good for blood pressure. And you may have also heard other people say that that's not necessarily true, that not everybody is salt sensitive. So it's true that some people's blood pressure is more salt sensitive than other people's blood pressure. What's interesting too is that people's salt sensitivity can change during their lifetime. So first of all, as people get older, it seems that many people tend to become more salt sensitive. And then your salt sensitivity can also be related to how your kidneys are functioning, how your heart is functioning, and how other aspects of your health are. Some characteristics of people that are associated with being more salt sensitive, meaning that in studies, these people get more blood pressure reduction in response to a lower sodium diet, include being Black, older age, and having hypertension. And then reducing dietary sodium was studied specifically in older adults in a trial that was called TONE, Trial of Non-Pharmacologic Interventions in the Elderly. So this was a study of 975 adults. They were aged 60 to 80. They were already on one blood pressure drug, but their blood pressure was not that high on the drug. So they were essentially at goal, kind of, less than 145/85. And then the intervention was to get them to reduce their sodium and then to see if they could be taken off the medication. And what they found is that when people reduced their sodium to less than 1,800 milligrams a day, it reduced their blood pressure by 2.5 millimeters of mercury. However, the blood pressure reduction was more significant when it was combined with weight loss. And that was for participants who had some obesity. And this, I think, highlights something that does come up with the lifestyle measures, is that often they work better when you combine them. So I think reducing dietary sodium is something to consider, especially if you're going for a lifestyle approach. We also know that sometimes medications tend to be more effective when people have reduced their dietary sodium as well. So if you want to go this route, I would recommend aiming for daily sodium at the range of 1,500 to 2,000 milligrams per day. Ideally, you're going to stay below the 2,000 milligrams per day. Now, what about potassium and blood pressure? People have sometimes heard that potassium can help with high blood pressure. That is actually true. This has been studied several times. And in a meta-analysis, they concluded that in people with high blood pressure, increasing the potassium intake reduced systolic blood pressure by 5 millimeters of mercury. Now, no reduction in blood pressure was seen in people who had normal blood pressure. So this is another thing that works in people who are hypertensive, not so much in those people who are already at a level that's close to normal or optimal. So how can you increase potassium? So potassium is naturally found in lots of fruits and vegetables. So increasing your intake through more fruits and vegetables is one way to do this. That is potentially part of the reason why the DASH diet works. But it is also possible in some cases to take potassium supplements. That's sometimes recommended, especially in people who have low blood potassium levels or who are on medications that lower their potassium levels, because there are some medications that do that. And then there are also salt substitutes that involve potassium chloride. So if you are thinking of those, what's important to know, especially for older adults, is you want to be very careful with those kinds of supplements or salt substitutes if you have any kidney disease. And that's because when people have kidney disease, their potassium tends to go up. And if your potassium is too high, that can actually interfere with your muscle function and be dangerous. You know, that's actually a method of lethal injection, is to give people a lot of potassium, because when you make people's potassium levels really, really high, their heart starts to skitter and will eventually skitter and go kind of nuts and then stop. So you do want to be careful with potassium supplements or salt substitutes. if there is any kidney disease or if the person is taking medications that affect electrolytes. And those include many diuretics and some blood pressure medications. And then what about any other lifestyle approaches for blood pressure? So there are some approaches that have been less rigorously studied, but they also seem likely to help reduce blood pressure. They include things like yoga, meditation and mindfulness, stress reduction, treatment of insomnia, quitting tobacco. So if you are wondering about, well, if I do these, will it help my blood pressure? Probably, would be my guess. These are all things that in a way kind of reduce a state of chronic stress and help people be more relaxed. And that tends to lower blood pressure. We just don't know quite as much about it. But I would recommend it because these things are all good for your health for many other reasons. So that's lifestyle measures for blood pressure. And lifestyle measures are great, but the truth is that often they are not enough. They can be hard to implement. They require often effort, they require commitment, they require sticking to it for weeks or months to, well, first of all, many of them you need to do it for at least probably 2 weeks to see if it's having an effect on your blood pressure. And then you need to be ready to continue doing it indefinitely. And that can be a lot. So let me now talk about medications. Now in geriatrics, we are often fans of, less is more. We often try to minimize medications. But I have to say, medications do work extremely well for high blood pressure. So this is a situation where we are more likely actually to use medications. Now, we're often using smaller doses than other providers. We're not aiming for as low a goal as the cardiologists do. But I know many people who are a little leery of medications, and I think that's justified. And this is one case where we have lots and lots of evidence of medications working quite well and improving outcomes. So first of all, medications in almost everyone will lower blood pressure. And we see an effect generally within days. And then not only do they lower the blood pressure, but they lower those bad health outcomes that are the result of high blood pressure. And this has been shown over and over again in randomized trials, such as the SPRINT trial, which I mentioned in the previous video, one of the landmark trials of blood pressure control in older adults. There are others too. There are trials called SHEP and HIVET that have shown this too. So we have seen that when we treat people with blood pressure medications and we successfully bring down their blood pressure, within just a few years, you can see reductions in cardiovascular events, in strokes, and in mortality. So again, I think lifestyle measures are great. I think we are underusing them, and it is often hard for people to reach their goal blood pressure with lifestyle measures alone. So I think it's important to be open to considering medication, especially if your systolic blood pressure is above 150. Because in most cases, even though many blood pressure medications do have side effects, either common side effects or occasional bad effects in certain people, despite that, in many cases, possibly even most cases, the likely benefits of medication treatment outweigh the risks. So what are the medications that we usually consider when we are trying to treat high blood pressure? This has been studied a lot in randomized trials. So there are expert guidelines and sort of first-line treatment recommendations that are well established. And this is what they are. So for initial treatment with a single drug, or possibly sometimes if people's blood pressure is quite high, they might start right off the bat with 2 drugs. But there are 3 key classes of blood pressure medication that are considered first-line therapy. They have a good, well-established track record. So unless there's a compelling reason to not use any of them, if somebody is diagnosed with high blood pressure, this is where health providers should be starting. And those 3 types of blood pressure medication are, one is long-acting dihydropyridine calcium channel blockers. I know, it's a mouthful. So these are medications. I'll go through a few more examples in a moment, but a common example would be amlodipine. The brand name is Norvasc. Another class of drug that is considered a first-line therapy is a thiazide diuretic, such as hydrochlorothiazide. And then a third class, or you could say this is class 3 and 4, is an ACE inhibitor or an ARB. So I'm going to explain this type of medication in a moment. These 2 are extremely closely related. You would usually use either one or the other, not both of them together. And a common example of an ACE inhibitor would be lisinopril. or of an ARB would be something like losartan. So sometimes we do also start with combination treatments. There is some evidence that that can be a little bit more effective. The downside is that if somebody's having side effects or it's not agreeing with them, then it's a little bit more complicated to figure out, which medication is the issue. But if we are going to start with combo treatment, this would involve using 2 of the 3 above drug types. That is what is considered kind of like the initial way that you are supposed to attempt to manage high blood pressure. Now, you may be thinking, well, I have high blood pressure and my medication isn't one of these. Well, there are many other medications that affect blood pressure. And some of them are specifically recommended for people who have certain types of heart or kidney conditions. Or in other cases, people haven't tolerated the initial set of medications that are recommended for first-line therapy. Or some people have such difficult to manage high blood pressure that we just end up having to go to, sort of the second line therapy medications as well. Let me now talk about those key types of blood pressure medication in a little bit more depth. So first of all, calcium channel blockers. For blood pressure, what we want is the long-acting dihydropyridine calcium channel blockers. There's another type of calcium channel blocker that acts less on your blood vessels and more on your heart. It's sometimes used to treat, atrial fibrillation or conditions like that. But the long-acting dihydropyridine ones, most commonly used in the United States, would be amlodipine, felodipine, nifedipine. The brand names are Norvasc, Plendil, and then nifedipine goes by both Procardia and Adalat. These act mainly by relaxing your blood vessel walls. And the advantage of these is that they don't really affect electrolytes. Many blood pressure medications affect electrolytes, but these do not. So that means less lab monitoring required, which can be nice. And then a common side effect is that they can cause leg swelling at times. Next, thiazide diuretics for high blood pressure. So the main one we use in the United States is hydrochlorothiazide. Another one that is used, especially in other countries, is chlorthalidone. Now, there are other types of diuretics that exist as well, such as loop diuretics, such as furosemide, often prescribed for people who have heart failure. That's not the same kind of diuretic. So these are thiazide diuretics. And the way they act is they increase sodium and water excretion in the kidneys. Generally, these are well tolerated, but they do require monitoring of electrolytes because while this medication is changing how you excrete sodium, it's also affecting how your kidneys process certain other electrolytes. So some common side effects. The way this works is it does make people pee more. That can be an issue for some older adults, especially if they are already struggling to manage their urination and their continence. And then it can lower blood electrolyte levels, especially potassium levels, sodium levels, and magnesium levels. This kind of diuretic also tends to increase blood levels of calcium. This is sometimes considered a good thing for people who have osteoporosis, but it also increases uric acid, which can exacerbate a condition such as gout. Despite these side effects, these medications are often used, including in older adults, and generally do have a good track record. And then let me now talk about ACE inhibitors, and then I'll talk about ARBs. So ACE inhibitors include medications such as benazepril, lisinopril, and many, many more. If you Google, list of ACE inhibitors, you'll see lots of them. And the way these act is that ACE inhibitors inhibit an enzyme that is called ACE, which is an angiotensin converting enzyme, basically. And so that reduces levels of a substance in the body, a vasoconstricting substance. So that means it tightens up your blood vessels. That is called angiotensin 2. And so ACE inhibits the conversion of, I think it's angiotensin 1 to angiotensin 2. And so you have less angiotensin 2, and so your blood vessels don't stay as constricted as they otherwise would. This is another medication that we have a pretty good track record on and is often well tolerated, but it does require monitoring of electrolytes and kidney function. An ACE inhibitor almost always raises somebody's potassium a bit and it will usually raise their creatinine a little bit, which is a measure of kidney function. And those small changes are expected and are okay. We basically monitor to make sure it's not a large change. So these will tend to increase potassium levels. And then side effects. ACE inhibitors can also have certain side effects that are specific to them. So one is cough, actually. And another one is angioedema, where people get face swelling. So both these side effects are not something we expect to see in everybody. They affect a minority of people, though. And if people are having that side effect, generally we're going to want to switch them to an ARB, which is a related drug that I'm about to tell you about, but doesn't have those side effects. And then we're generally looking out for problematically high potassium levels and significantly worsened kidney function. So what's interesting about ACE inhibitors is despite the fact that they make your kidney function a little worse, they actually have been shown to be renoprotective. They actually protect the kidneys from ongoing damage from conditions like diabetes. And they also help protect the heart when the heart has been previously damaged. So they're often actually a good choice if people have diabetes or for certain heart conditions, such as having heart failure. So it's a little counterintuitive, but if people have those conditions along with their high blood pressure, then we'll be especially likely to want to use either an ACE or an ARB because they can be kind of interchangeable. So ARBs. ARBs are kind of working in a very similar mechanism of action. What they do is they block the action of that angiotensin 2. They are an angiotensin receptor blocker. So both the ACE inhibitors and the ARBs result in a decreased effect of that angiotensin 2, just through slightly different mechanisms. So similar to ACE inhibitors, they're generally well tolerated, but also require a little monitoring of electrolytes and kidney function. With ARBs, we do expect to see a little rise in potassium and a little worsening of kidney function. But otherwise, ARBs do not have this side effect of cough or angioedema. So with those, we're generally just, again, monitoring potassium and kidney function. And ARBs are also renoprotective and cardioprotective. So also often a good choice if people have diabetes, heart failure, or certain other conditions. So generally, when it comes to managing high blood pressure, we would use either an ACE inhibitor or an ARB, generally not both of them together. So if we're doing that 2 out of 3 drug combination, you would not expect to see the ACE inhibitor and ARB together. It would be one of those two, along with something else such as a calcium channel blocker. Now, let me briefly speak to another type of blood pressure medication, which you may have heard about before, which are beta blockers. What about beta blockers? So beta blockers, there was a time actually when I was in medical school, beta blockers were prescribed for primary hypertension all the time. So this is a type of blood pressure medication that works by slowing down your heart rate. And some commonly prescribed ones include metoprolol, atenolol, carvedilol. The brand names there are Toprol, Tenormin, and Coreg. So they were for a time often used for primary hypertension, but what was found through a lot of research was that they were not great for that, especially not in older adults. So they are no longer recommended for the treatment of isolated hypertension. If a person has hypertension without having another type of heart condition for which beta blockers are good, they probably shouldn't be on a beta blocker. Beta blockers are definitely helpful when it comes to certain heart conditions, especially heart failure or recent heart attacks. Otherwise, certainly at UCSF, a lot of primary care providers a while back made an effort to transition their patients who have primary hypertension from a beta blocker to one of those other 3 drugs that I mentioned. So let me now speak to what is most important, in my opinion, for blood pressure treatment. So studies have found that it's really the attained goal blood pressure you get to that's most important, not which of those 3 drugs. But what's important is that you get accurate blood pressure measurements initially and as you are treating to see what's going on. You want to use good technique. Combining home measurements with office measurements is best. Please always include your heart rate with your blood pressure measurements. You want to take your medications as directed, or if you are supporting an older, frailer person, you will want to make sure they are taking their medication. This comes up sometimes with some of my older patients, especially if they're older, live alone, and maybe have been having some memory problems, right? Sometimes people's blood pressure is out of control, and it's because they haven't been taking the medication. So we don't want to be changing or increasing the medication if the issue is that they haven't been taking it. If you are in treatment, especially if there's been a change or you've just started, you want to ask what kind of high or low blood pressure should prompt a call to your doctor. And then you want to get follow-up and adjust treatments. A follow-up in 2 to 4 weeks to check blood pressure, to check for side effects and adjust medications is often reasonable. Let me now speak to some special considerations that affect older adults, especially once people get into their 80s and older. So what we know is that as people age, systolic blood pressure tends to go up and diastolic actually tends to go down. This is related to the stiffening of the arteries that affects most people as they get older. It affects everybody. It's just a question of how fast and when. So as people get into their 70s, 80s, 90s, it's very common for them to have something that is sometimes called isolated systolic hypertension, where the top number is very high, but the bottom number, the diastolic, is quite low. So some of the blood pressure management issues that come up in later life that we are often dealing with in geriatrics, but that are also affecting other primary care providers. One is people get much older, their blood pressure can be extremely variable, where sometimes it is really, really high and other times it is barely high. They can have quite low diastolics, such as 60 or sometimes lower. People sometimes are asking me how low is too low. What I say is, how is the person feeling, when they stand up? If they stand up and they feel weak or dizzy, that's probably too low. If their diastolic is 55, but they're feeling fine, even when they stand up, then I would worry a little less about it. As people get older, they tend to become quite sensitive to blood pressure drugs or to their side effects, so they might need more caution and monitoring because of that. Another issue is that a lot of people might have a low systolic blood pressure when they stand up. And especially as you get older and frailer, that lower pressure might either mean that you have less blood flow to your brain. And we see some people who seem to actually sometimes get a little bit more confused, if not lightheaded, when they're standing, when their blood pressure is low. Or there are some people whose blood pressure drops a full 20 points when they stand up. This is something that is called orthostatic hypotension. It means dropping your blood pressure when you change position. It's a known issue that is very common in older adults, especially if they are on blood pressure medications. And it can increase the risk of falls. If a person stands up and for the first few minutes, their blood pressure drops 20 points, and this is often happening because the mechanisms you have in your body that are supposed to make adjustments to keep your blood pressure stable, because when you stand up, your blood falls into your legs. It's what it wants to do unless your body very quickly makes adjustments. And when we're young, our body is good at making those adjustments. And as we get older, it gets worse at that. So that's another issue that we're often checking for in geriatrics as well. So in geriatrics, especially for adults who are age 80 or older or are frail, we tend to, first of all, aim for a systolic blood pressure goal of 140. It was shown in Sprint Senior, which was in people, age 75 plus, that aiming for that lower blood pressure goal of 120 instead of 140 did improve outcomes. So we know it works for older adults. We just generally first try to get to 140 and then really check and make sure, see how the person is doing before we aim for lower. And again, I talked a little bit about Sprint in the previous video, but there were many frail older people who were actually excluded from Sprint, including people with Alzheimer's and other forms of dementia. So we, tend to go more of the line of, the European guidelines and aim for systolic 140. We do a lot of monitoring for signs of overtreatment. I mean, if somebody comes in to see me and sitting down, their systolic blood pressure is less than 120, I don't say, yay, I get concerned. I say, are you feeling okay when you stand up? Let's check your blood pressure when you stand up. How much blood pressure medication are you on? Do you really need to be on quite as much? Should we think about scaling back a little bit? I think it's good to treat blood pressure. I'm just not always convinced that we need to be super aggressive about it, especially if there have been any concerns about fall or frailty. So again, we're quite likely to check for orthostatic hypotension. We will also check on medication adherence, especially before increasing medication dosages, especially when it comes to people who live alone or have had any issues with their memory. We also check often on electrolytes and kidney function. Many people, as they get older, are more prone to have poor kidney function or to develop electrolyte imbalances in response to medications. And then I'm a big fan of home blood pressure monitoring. The more data points, the better. And in general, we tend to manage blood pressure in light of the greater picture of the person's health, their overall health status, their goals of medical care, their other health conditions. Some people have lots of health problems going on at the same time, and it just may not make sense to be really aggressive about their blood pressure control at that time. Some people don't want to be on lots and lots of medication if that's what it takes to manage their blood pressure, and maybe we'll decide that it's reasonable for them to be kind of, have a systolic blood pressure of around 150, depending on what else is going on with their health and how much longer we expect they're likely to live. So to recap, how to lower blood pressure. So when it comes to lifestyle, the DASH diet is good. Low sodium DASH diet can be even better. So that would involve a high intake of vegetables, fruits, and the original DASH was low fat dairy. Also low intake of snacks, sweets, meats, saturated fat, and total fat. If you want to go a dietary approach, I would say change the diet. Remember to be your own test subject. Change your diets. Don't change anything else, actually. Check your blood pressure every day for 2 weeks. See what happens. That should do it. Exercise also helps lower blood pressure and is otherwise amazing for your aging health. I especially recommend strength exercises, but some aerobic exercise is good too for your aging health. And I have a whole video about aging and exercise if you want to learn more about that. Reducing alcohol intake is another thing to consider. It can help with blood pressure and also has other benefits for heart health and likely reduces your cancer risk as well. And then in terms of lowering blood pressure through medications are a very effective way to lower blood pressure, generally safe enough. Generally, the benefits outweigh the risks. For initial treatment with a single drug, 3 classes are considered first-line therapy. So that would be the calcium channel blockers, such as amlodipine, thiazide diuretics, such as hydrochlorothiazide, and ACE inhibitors or ARBs, such as lisinopril or losartan. Some people will also might start with a combination treatment. There are combination pills, actually, that can be given, which is convenient, or a small dose of 2 of those 3 types. And then just remember that many other drugs affect blood pressure. You might be prescribed something different, especially if you have a certain type of heart condition or kidney condition as well. And then in terms of how to lower blood pressure, you want to make sure the blood pressure is measured accurately. You want to make sure your health providers have checked for secondary hypertension and treated or removed any causes, including medications that might be aggravating your blood pressure. You want to decide on what goal blood pressure is being targeted. You want to discuss and implement lifestyle changes that lower blood pressure. Start or adjust treatment with blood pressure medication, especially if systolic blood pressure is above 150. Follow-up is key. Make a plan to follow up to assess the effect and side effects of the blood pressure treatment. Adjust treatment until goal blood pressure is reached. And then optional is to reassess the goal blood pressure, especially if you started off with a goal that wasn't less than 130/80. If you reach your goal, if that first goal was 140/80, you can reassess and maybe decide to aim for a lower goal. So thank you so much for watching. And if you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe. It does help more people find the channel. If you've been listening to the audio version on the podcast feed, please come and take a look at the video if you get a chance. You'll see my key points being displayed on the screen. So thank you again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.